Welcome to the Sisters for Prevention YouTube channel and podcast. Today, it is my great pleasure to have as my guest, Abigail Johnston. Abigail is a dedicated breast cancer advocate who has made significant contributions to the metastatic breast cancer community. She was diagnosed with DeNovo stage 4 metastatic breast cancer in 2017 while tandem breastfeeding for two young children who were then 1 and 3 years old. Since her diagnosis, Abigail has focused on patient advocacy, leveraging her experience and training as a lawyer to support others in the MBC community. She has been involved in various initiatives, including legislative advocacy with organizations like Metaviver and Force. Abigail also runs the mentoring program for MBC patients at Project Life and holds legal clinics for Project Life and the 305 Pink Pack. In addition to her advocacy work, Abigail is a contributor to advancedbreastcancer.net and regularly blogs at nohalfmeasures.blog. She is also involved with survivingbreastcancer.org, where she moderates the MBC Sunday series and chairs the MBC Leadership Committee. Abigail's efforts have been instrumental in providing education, connection, and support to those affected by metastatic breast cancer, making her a prominent figure in the advocacy community. In a recent meeting, I spoke with Abigail and we discussed the term survivorship and how or why this may not apply to metastatic patients, because metastatic patients will be on treatment for the rest of their lives. So it's my great pleasure to welcome Abigail and get her view on this topic. Hope you enjoy the program. Really interested in what you said about the word survivor. So I just want to give you a chance to, can you tell me your feelings about that? Because I'll be very honest with you. I have a lot of friends who are metastatic, and I'm so happy to hear that because I need to be more sensitive, I think.
Yeah, no, I think that labels in general are problematic, right? So not everybody resonates or agrees with particular labels.
Yeah.
And I do think those of us who are diagnosed de novo, meaning metastatic from the beginning, we may have a very different experience with the word survivor. Personally, for me, survivor is past tense. Survivor means something is over. And for those of us who are metastatic, cancer will never be over. And so it doesn't work, right? It doesn't, I understand that the prevailing definition out there is that as soon as someone is diagnosed, they're a survivor. And I get that particular thought process. It just doesn't work for those of us who cancer will never be gone. Cancer will never be in our rearview mirror. And I say this with my mother's a survivor. There are multiple previvors in my family. And so there are different experiences. And I'm not talking about value judgments. I'm not saying one is better or worse or whatever. All I am saying is that those experiences are very, very, very different. And while the definition may be a survivor is someone from diagnosis to beyond, how treatment happens affects very much how we're treated in the context of our medical systems. So survivorship programs, this is changing, but those are almost universally only extended to people who are not in active treatment. And so even in our medical system, we're defining somebody as being a survivor as somebody who's not in active treatment based on services. And I understand we have to draw the line somewhere. Those of us who are always in active treatment, I've been in active treatment for more than 7 years at this point. It's a very, very different experience. And then we don't even get access to the small things that are offered to people. And I say that very intentionally because survivorship programs generally are not where they need to be. None of us are supported in the ways that we need to be supported. My whole point is just that you can't lump everyone together under that category of survivor, and we may want to, and maybe for numbers right? That makes sense, right? To calculate how many people are affected by cancer. But when it comes to the actual experience and when it comes to the actual needs and when it comes to the effect, someone who's metastatic it's a completely different category. And even within metastatic, there are different categories because the different subtypes and the different treatment options and the different, how things progress based on subtype, meaning going to different places first, that sort of thing. That's even a whole difference. And so that's where labels for me is something that people should ask.
You were diagnosed that when you were actually still in active nursing your child. Was that
my two children? I was tandem breastfeeding.
Oh, tandem. That's what you were tandem for law practice, and you've left that now to be an advocate. Is that still true, or?
Yes, I closed my office because they said you have 12 to 36 months to live. And I wasn't going to spend that time in the office. I wanted to spend that time with my children.
Oh my goodness gracious. And how old were the children at the time when
obviously they turned 2 and 4 in the middle of me getting diagnosed. So I was initially misdiagnosed because the cancer center that I went to initially didn't follow standard of care and gave me a stage without scanning me. But you don't know what you don't know at the beginning, right?
So I always say that my heart is really going out to, and I'm better getting breast cancer while they're nursing their babies.
There's nobody who is really focused on or paying attention to your breasts while they're being used for this purpose, this nursing. And that was actually something that was astonishing to me. I actually was part of a milk sharing organization. I donated over 25,000 ounces of breast milk while I was nursing my boys. The number of people, somewhat ironically now, right, that had their baby and were wheeled down to the chemo suite, never could breastfeed their babies. That was a big part of where the milk that I donated went. And so, of course, ironically looking back now, but nobody wants to talk about that, right? Because the focus is on encouraging women to breastfeed, which
it's supposed to be
I believe that's important.
Nursed both my boys because they're 40 and 43, but at the time they told me it was protective of breast cancer. But I agree with you.
Longitudinally, it is. It is longitudinally. When you have your children, how old you have, there's all these factors that are actually protective. That nuance, it's hard to explain to people. And I understand that nuance is hard to explain to people because the focus is we want more people to breastfeed. Certain populations are much less likely to breastfeed, right? White women are much more likely to breastfeed, whereas people in minority communities are not. In fact, it's a complicated subject and there is very little support. I was 38 at my diagnosis and I was not told that I was too young for breast cancer. However, I know so many women who were in 20s and 30s who were told, oh, it can't be that. Now I was told, I'm 95% sure it's nothing. This is my PCP. 95% sure it's nothing. However, I'm going to send you for your very first mammogram. I was too young for screening, right? Didn't start any screening. Well, I could have because my mother had breast cancer, but I was pregnant and nursing. And, you don't do extra radiation if you don't have to. I was very fortunate in that my provider took things seriously, even though she was 95% sure it wasn't anything to be concerned about. I've
been having meetings with people about this thing, and I recently got an oncologist to say to me that from 6 months to 9 months, there's a point in there where your estrogen level makes you very susceptible to breast cancer. And no one has ever told me that before. I kept asking this question and they kept saying, oh, no, statistics don't prove it. I just feel like something has to be done about this to screen if women have, like I had mastitis a couple times when I was nursing, so if it happens in the 6 to 9 months, and let's assume it's slow growing or it's not going to show up until you're nursing because you're paying more attention to your breasts at that point. There's got to be research on this, and nobody is doing any research on it. So,
oh no, there are. At the last couple of San Antonio symposiums, there's been presentations on this right after pregnancy, breast cancer. Yes, no, there are definitely doctors doing research on it. In fact, the unfortunate thing is that your life expectancy is about half if you are diagnosed postpartum versus if you're diagnosed while you're pregnant. In fact, it's a much more significant, and they've extended it to, I believe, 3 to 5 years after pregnancy, that you have this poorer prognosis. And how it's been explained to me is the intense rise in estrogen for a specific period of time, i.e. pregnancy, that's okay. It's the fluctuations or the consistent low levels of estrogen, i.e. Birth control, that actually causes the extra risk. And so extended breastfeeding, which is what I did, I nursed and pumped for 4 years straight through my first son was born, and then through my second pregnancy and all of that. So I was consistently keeping my estrogen levels high. And that is the danger. It's the high levels of consistent estrogen for an extended period of time that raise your risk for breast cancer. And so that is, to me, that is the discussion I think that needs to be had. That if many people struggle to breastfeed, and that was one thing that my body did correctly. We had to do a lot of fertility stuff to get pregnant. So I think I was like, ooh, my breasts are working. This is great. But also I really bought into the idea of normalizing the time period of breastfeeding and not, cutting my children off, not arbitrarily weaning them. That I didn't know. Nobody told me. Nobody sat down and explained to me that I was creating potentially a situation where there was a greater risk. Now, I have a germline mutation. We have ATM in our family, and the particular ATM mutations are as or more risky than BRCA. So a lot of people don't know ATM is a moderate risk gene, but there are specific mutations that are as risky or even more risky than BRCA. It was a perfect storm. I had the genetic predisposition, and then I put myself in a situation where I was elevating my risk without even knowing. But yes, nobody explained that to me. And that's only been something that I've really looked into since my diagnosis to really understand. And then, talking to my lactation consultant friends to talk to their people, yes, it's important to support people in breastfeeding. Yes, it's important to talk about the positives, and all of those things are important. Then talk about the need for screening and the need for self exams and the need for taking things seriously if something comes up.
Well, that's really interesting, because I nursed my second child till he was almost 3. I got breast cancer at 53, but I had bilateral breast cancer and I was misdiagnosed. The invasive tumor didn't show on the mammogram, but you just brought in a new thing that I'm really worried about too. So this idea of fertility treatment. I mean, IVF is still, I know it's 50 years old or whatever, but we don't really know. Like you said, you don't know what you don't know. Are we really following? Have you seen something like in San Antonio that I've missed too, where they talk about IVF treatment and breast cancer?
No, that's the thing. It's interesting because the cancer in my body is very sensitive to estrogen and progesterone. We did not get to the point of IVF. I was doing injections and oral medications. IVF would have been our next step. It never fully, they said it has nothing to do with it. But I'm saying to them, I'm injecting myself with the very hormones that feed the cancer that showed up in my body. So, it seems to me that there is a connection, but the medical system generally is very resistant to connecting fertility treatments to cancer. And I've talked to a lot of doctors about that. I don't know, but I do think that it is something that we need to be really considering. I mean, they didn't really explain the risk that birth control was causing people until they had to. And this is consistent, right? Anytime there is a medical procedure or medication or whatever it takes a long time for the system to acknowledge the potential risks. And I don't think you're right. I don't think they follow people long enough to really pay attention. But one thing that I think would be super important is to offer genetic screening prior to fertility treatments. And that was something back. So my older son was born in 2013. Obviously, there were issues with BRCA being patented, and that ended in 2013. So genetic testing was less available back then than it is now, which is good, because I think that information would have been helpful for us to have known. Not that we would have made a different decision, but I think it would have been helpful for us to have known. And so I do think the place for making adjustments would be to focus on making sure that people are offered genetic testing and genetic counseling prior to undergoing fertility treatments. In my view, just, having come from having a germline mutation, it would have been very helpful to have known that. I don't know that they're going to connect those dots anytime soon.
I can't imagine the burden of being diagnosed de novo. I hate it when they quote statistics, because, I just lost a really good friend, Ann Fonfa. Did you know her? Ann Fonfa from Annie Appleseed. And she lived like 24 years with what they told her at the time was stage 4, which was incorrect.
And that's still the people that live a long time, those are still the outliers. The vast majority of people, it's only 28% of us that get 5 years. That is a real statistic. Mm-hmm. And that number has not changed. That number has not gotten better over time, even with mammograms and, like the early detection type stuff and all of that, like that, none of that has affected the rate of death. And that is something that is a reality. And so, yes, we are not statistics. I 1000% agree with that. But I also don't believe in glossing things over. Those of us who are diagnosed premenopausal, the statistics are even worse. And so I am thankful that my doctor gave me a realistic, like, this is what we know, this is what we have. He told me that, it could be longer, but that I had thousands of Mets at diagnosis. My disease load was super high. I had bigger tumors in my femurs than I ever did in my breast. So it had spread very early without us knowing. And I didn't say anything about my leg and my back hurting when I got diagnosed with breast cancer, because to me, my breast had nothing to do with my leg, right? So again, what you don't know. My original team is, as I've circled back and talked with them later, they're very surprised that I'm still alive. There are some things that I think that went into that, but I do think it's important to set people's expectations, because I am seeing a disturbing trend where doctors are treating people newly diagnosed with curative intent. Breast cancer is not curative. We can't cure breast cancer, but they're treating people more aggressively and with curative intent. And a lot of doctors are beginning to talk about the possibility of cure. I'm not saying that's a bad thing. I just think that it's important to be realistic. And a lot of the people who are treated with curative intent aggressively at the beginning, when they have their first progression, when the cancer does what cancer does, which is mutate and grow and get around medication, they have a much more difficult time adjusting to the reality of metastatic breast cancer, which is you have progression and you have to change treatments, and it's an ongoing, continuing thing, absent the few people who are able to stay on one line of treatment. And there are those people, but again, very, very, very small minority. So I think it's important to tell people the truth. And in my experience dealing with doctors, they're scared to tell people the truth, to give people the unvarnished truth, and they're not trained on how to do it either. So anyway, it's a complicated thing.
Well, you raised another good point too, because the standard of care, as we know, is not universal, because of, if you go to a cancer center, breast cancer center, versus you get treated in a local hospital. I never realized myself that once you receive one chemo, that chemo will not be effective to be used again. So in
Well,
other
that's
words,
not true. That's not true for all medications.
oh,
It's true
okay.
for some. It's true for
So,
some.
okay.
Yeah, yeah. And the initial medication that's typically given as standard of care for early stage treatment, yes, you can't go back to adriamycin. There are others that you can return to later, and that happens a lot in the metastatic setting.
Okay. Because the cancer mutates, right? Is that why it does, or is that not correct?
That is the theory.
Okay.
Not all mutations are testable. Not all mutations show up on testing, and not all mutations are actionable either. So, but yes, the prevailing wisdom is once you've had one medication and you've had progression on that particular medication, you typically do not circle back to especially chemotherapies. Now, targeted treatments are a little bit different. There are classes of medication that you can re-challenge, that you can come back to. I don't see a lot of doctors doing that. I think generally they like to move on to something else and try something new, try something novel. There are medications that you can return to with all kinds of safety measures in place, of course.
If you don't mind me asking, so the medication you're on now, you're on infusion. Is it a
I'm on
week?
Enhertu, which is an ADC.
Oh, yeah, and her too. So how many times have you had to change?
This is my 7th line of treatment.
Wow.
Or my 9th, depending on how you count lines of treatment.
How is the quality of life? I know you said it takes you a couple of days. Is it fatigue? Is it nausea? Is it all of the above?
Yeah, stuff. Yeah, no, I think one of the biggest quibbles I have with doctors generally is that on ADCs generally is that they believe it's much more easily tolerated than traditional chemotherapy. That is not true for most of us. I think honestly, anytime anyone who has not had a medication offers an opinion on how tolerable said medication is, I stop listening. Because if you haven't actually had the medication and haven't had the experience, it's not as valuable for someone to opine about it being tolerated. I think the danger with doctors saying anything, positive or negative, about medication is you set expectations.
Mm-hmm.
And I know a lot of people who they worry when their experience doesn't match what their doctor told them they could expect. And so, yes, we all need to know what's possible. We need to know potential side effects. We need to know all of these things. But it really concerns me when healthcare workers who have not had medication feel free to communicate how they think a patient should do on a medication. I've been on multiple chemotherapies, including adriamycin, including Taxotere, Cytoxan, and HER2 is far worse than chemotherapy, as it has been for me. Anyway, we've recently done a dose reduction. My hope is that it will go a little bit easier while still being effective, because it has been very effective so far, which is what we need. Patients generally need more thought, I think, into what's really tolerable. I think doctors get really excited about the science, and that's great, and that's their job, and that's their thing. The idea that what I've experienced is medical oncologists they get tunnel vision. That if it's working, if it's killing the cancer, then okay, check the box and move on. Whereas I think patients need a whole lot more support in dealing with and handling the effect on our quality of life, especially as we're living longer, because we don't have longitudinal data on most of these meds and what it looks like when we've been on these medications for 5, 10, 15 years, because we don't have that information yet. And so it takes a toll on our bodies in a way I don't think doctors really pay attention to, in my opinion.
Well, one of the things that I've been trying to do, and I've got nowhere with it, is so going back to the optimum dose, Project Optima and the optimum dose and cutting back on dose and things like that. But like dealing with the research team, I think they would be looking for the answers to why some of this medication is reacting in the patient if they knew what the patient was experiencing.
Yes, but this is the problem, because I've been in 6 clinical trials personally. Wow. 6. Right. And I am telling you, they start at the beginning and decide what questions they're going to ask.
Right.
And they never change that.
Right. I
So
know.
the trials that I have been in, as I was trying to give that feedback, they're not accepting it because that's not something that they're collecting. That's not something that they want. And so that is why I think that that patients need to be involved in the design of clinical trials from the beginning, and not people who are not metastatic. People who are in these trials are the people who are metastatic. Those are the people that need to help design the trials from the beginning, because we're the ones who are actually experiencing them. And I've consulted on dozens of trials at this point, and they never bring patients in at the very beginning. They've already set all of these things. And I believe you're right in that, although the PIs in my trials are my treating doctors. And so there's not a distinction between the research and the clinical. There are people who are wearing both hats, at least in my experience, because that happens. But the problem is that it's too rigid, and they set what they want to receive, or they set what they think they're needing to receive at the beginning. Whereas they need to continually check in with patients and continually get some of that feedback, but they're not, because they set it at the beginning and they never adjust it.
But also, problem I have is that you may be sick last week, but you go to the doctor this week and you feel pretty good. So they ask you, well, how do you feel? So you say, well, I feel pretty good, but I forgot that or maybe I didn't forget, but I'm so afraid of being taken off the drug that's working that I'll say, I'm okay. I made it through it. What I think we need to have a simple app that says, good morning, how are you feeling today? List anything that seems unusual to you, because this came off to me. My husband was on Ozempic and developed uncontrollable hiccups. And we went to the doctor. He's like, that's not one of our criteria of Ozempic. It's not. So I went back to the clinical trial and looked up the trial. And at the very bottom, they said something about, in rare cases, patients experience, but it wasn't listed on the medication. What I'm saying is that we're not listening to patients, like you said. We're not accurately collecting the data, and we're not circulating that data to the people administering the drug. And so,
did you file an adverse effect report with the FDA?
I'm guilty. I did not. So I need to do that. Okay.
That's the regulatory agency.
Okay.
that when there is an indication, right, an adverse event, that the FDA has the power to go back to the pharmaceutical companies and ask them, to collect data or to look into it or whatever. But other than that, that's the remedy. That there aren't other remedies. And several of my doctors have, when they get the paperwork, when I've reported something to the FDA, they give me the paperwork to fill out, because it's a lot of paperwork. Yeah. And I understand that puts a burden on our treating doctors, because then they have to provide the documentation, etc. But the FDA is the only regulatory agency, as far as I know, that has a process for something like that. But the problem with all of this is, I believe, no doctor, not one, can be an expert on all of these drugs. There's no way. Right. There's way too much information out there. Right. And so that, I believe, puts an unfair burden on patients. Somebody like you who's educated and can go back and look to see if there's a, potential adverse event. That is not the norm, right? When we're struggling with basic health literacy and people showing up for screenings, we can't make it so hard and so complicated for patients to navigate all of these things. Do I believe that doctors have a responsibility to be more, to shut people down less, right? 100%, I do. But it's the system generally. It's not just the doctors that are putting this unfair burden on patients, in my opinion. My background is not in health stuff. This has had to become something that I've had to really focus on since my diagnosis. I think at last count, I have caught about 60 medical mistakes in my treatment. And the very first being, they didn't give me a scan when I asked for it. to see if the cancer had escaped my breast. They said that, statistically that it probably wasn't the case. And, I really didn't need to have a PET scan prior to starting chemo. When now I know that's the standard of care. Now I know that's what they should have done. That kind of stuff happens all the time. In fact, the fact that I was stage 4 was actually caught by a medical mistake. Someone checked the box to check my tumor markers, not standard of care, not something that they should have done. Somebody accidentally checked the box to check my tumor markers, and that's what got me a scan.
But the other side of that as well, if I was allowed to enter what I feel every day, there's another side of that from the patient perspective, is that if I know if I know some people on this drug are feeling the same things that I'm feeling, but they're not on the list, it's going to give me a little bit more peace of mind to say, because of course, first thing in your mind is it's progression, a pain in my leg, or if I get dizzy or whatever, versus if I look on feedback from other patients and say, well, gee, it's not expected, but other people are having this experience. And the big thing, now being on a clinical trial team, is the confidentiality between the patient and the researcher. We get a number, we don't get a person. You can still maintain that confidentiality by if you had this feedback app or whatever you want to call it, so the researcher could look at it and then say back to the oncologist suggestions. I don't know. I just feel like we have this big disconnect. Yeah.
I agree with you that something like that could be helpful. And in the metastatic setting, we do this all the time. So okay. We are sharing in support groups all the time about, I'm in this trial, I'm doing this, I'm having this side effect, etc. I mean, that is a daily occurrence in the metastatic support group. So we, as patients, we are sharing that real world data with each other all the time for exactly that purpose. You're not crazy. It's happening to me too. The problem legitimately with open-ended questions like that is, and I'm not a statistician, but all the number crunching and all the things that they have to do in order to show that the medication is working, a lot of that information is not going to be statistically relevant. It's going to cause a lot of extra issues. You have issues with access. I mean, there are people in this country who don't have a cell phone, who don't have apps. And again, we're putting the burden back on patients to open up the app and fill it out on a daily basis. I am part of a research study out of Dana-Farber, it's the Young, Empowered, and Strong study. So it's specific to women who are diagnosed under 40 with metastatic breast cancer. They've really done a lot with surveys and calling. It's a longitudinal study looking at people who are in treatment for a long time. They've really struggled with exactly this. And how do you get statistically relevant information? It has to be a combination of, those rating 1 to 10 things. It has to be, some amount of free, filling out information, in a box or something. But it's a struggle because not everybody has access to the same things. Not everybody uses the same language. Not everybody is health literate. So there's just so many barriers that interfere. And to me, the design of the study is what is going to account for a lot of those issues. And again, they don't get patients who are actually going to participate in the trial. They don't get that population involved at the beginning, which they need to.
Well, the biggest issue too, is the only grants that are required to have patients involved from the beginning is the National Breast Cancer Coalition, CDMRP. NCI, NIH, all those other grant programs do not require advocates. This young investigator I'm trying to help to get funding, and they're putting the budget together, and somebody said, why do you need an advocate in there? And the other thing is, of course, we should be compensated for being on this, right? Because I fund all my own work. And so that needs to change. The NCI breast cancer and prevent program, I think we've come a long way. Obviously, I've been 2009, I was treated at Dana-Farber, by the way. They saved my life because my local hospital didn't find the invasive tumor. But I see you guys sorry, I'm a New Englander at heart. I use the word guys. It's a lot. Like Julia and Christine Hodgson, like metastatic patients that I have to admit, those of us that are not in active treatment, we have no idea what it's like, except if we talk to you, we don't.
And I get a lot of that, the reaction that I got in the meeting that we had the other day, which was somebody who was a survivor trying to say, well, it's similar, or it's the same, or the worry about a reoccurrence is the same as a worry about progression.
Mm-mm.
Those are not equal. Those are not the same.
No.
And it's frustrating as somebody who, and I'll say too, that people in the metastatic setting, like Christine and Julia, who have been either off treatment for years or stable on one treatment for years and years, that experience is also very different from those of us who go from treatment to treatment to treatment to treatment. Mm-hmm. And they would say the same thing, right? And that's, again, where generalizations, I think, are very problematic. Labels are very problematic. I do think that researchers generally, they miss out on not talking directly to patients, which is why so many of us go to San Antonio and so many of us go to ASCO and have these conversations directly with researchers. And you talked about a young researcher. I think that's the time to the time to get them, is at the very beginning, so that they begin their career understanding about the importance of involving patients. And I think as far as getting paid, there are a lot of people who will do advocacy projects and not accept payment. And some of that is because for those of us who live on disability, if we are making too much money on advocacy work, our disability can be reduced or even potentially taken away. And so a lot of people will forego payment because of that worry. And so that's where I talk to people, all advocates, all the time. If you are being offered money and you don't want it, right? I mean, whether it's disability or you don't feel like you want to take it or whatever the reason, so important to make sure it's still a line item in the budget. So you could say, donate my, whatever you would have paid me, donate it to wherever, so that it's preserved in as a line item. Or there are in-kind type benefits that you can get, like somebody paying for you to go to a conference, right? So maybe their budget could allocate for, you as the patient advocate on the trial to be able to go present at the conference. And so they pay your way. And that's where you're compensated as an in-kind type of thing. So there are lots of creative ways of considering how we make sure that those things stay as line items. But in my opinion, outside of some of these organizations requiring a patient advocate, which I think they should generally, every patient advocate needs to make sure that they are talking about payment like you are. Because if they, the ubiquitous they, right? If they know they can get somebody for free, they're not going to pay somebody.
Well, like what I've been on this vaccine trial team now for 4 years, and I didn't want payment in the beginning either, because I'd been supporting the researcher out of my own pocket for, it almost took 6 years before we got the funding. But what I said to him was, look, I'm going to put this money in a special, I have a special breast cancer account, and that money goes in that account. And that's what I use to go to San Antonio. I've been to Project Lead, all those things that I need. And I just feel like I'm recruiting 2 other advocates for this trial. Like, it's not fair. They're both very busy people. It's not fair to say, well, gosh, give me 20 hours of your time, but guess what? I'm not going to pay you anything. So now it's not only me involved, it's somebody else. And you're right. If we don't bring the patient perspective, then it's never going to get better.
It's not. Well, and I think the thing that can be challenging is we're all an N of one. So our individual experiences are our individual experiences, and not any one of us can speak for anybody else. a lot of times when I work on trials, I will do, polling, and I will, gather other people's experiences. So it's not just me, it's not just my perspective at the table, but you can't generalize very well. I mean, there are some things you can generalize about, but it's very difficult to take one person's experience and extrapolate that beyond that one person's experience. And I say that because also I have been out of step with most of the typical, quote unquote, whatever that is, breast cancer patient, having young kids, being in the middle of my career, not, the average age of somebody being diagnosed with breast cancer is still 60. I was 38 at diagnosis. I'm 45 now. My experiences and what I have to deal with in a daily basis in my personal life, very different from the vast majority of the patients that I run into, even talking with my doctor. I'm not the typical patient. And that is something that I think our medical system is really bad at, the whole idea of personalized medicine, the idea that we're all individuals and that we're experiencing things as individuals. Our system is based on generalizations. Our system is based on categories and buckets and all of that. And I get that. It just makes it really challenging as an individual to get the kind of care and kind of support that we actually need. And when it comes to trials, it's even worse, right? Because you're trying to strip away all the things that make people unique to get to the common denominator. And I'm not saying that that's necessarily wrong. It's just, as an individual, as a person, again, I've participated in a lot of clinical trials. It's really challenging to have your needs met while you are going through treatment when it is so rigid and so, the humanity in a lot of ways has to be removed in order for the scientific process to happen. To be that person whose humanity is being stripped away is not a pleasant experience.
I learned a very valuable lesson this year so our first patient on the vaccine trial recurred and passed away. And I became very good friends with her because I wouldn't normally have been able to know who she was because I'm on the clinical trial team, but she went public with her involvement in the trial. And we became really good friends. And I tried everything to get her on another clinical trial. And actually, I'd sent her to Dana-Farber and they offered her a trial, but she was in Ohio and she couldn't travel back and forth. But I just don't understand why they dehumanize people in a way, because you become patient, number 110. And
they don't usually call us patients. They usually call us subjects.
Oh, no.
There's a lot of dehumanizing language that medical professionals use, and the explanation that I've always been given is that they need that professional distance in order to keep doing what they're doing, right? Because your experience, people die, and that is a norm that, especially in phase 1 trials, that as you're looking at toxicity and as you're looking at what people can handle, of course there's going to be adverse events. So I get it. There has to be a certain amount of professional objectivity, but as a human being, it doesn't sit well.
Yeah, but also there's a patent involved with the researcher, right? And so there's this, which there should be, these checks and balances to say, I'm not going to skew the results because to make my drug look better, because I have a patent and of course I want to make money. So that's problem number 1. But there's got to be a better way, because
one person's experience or a small group of of people's experiences, that's not relevant. That's not helpful. You need the broader experience to know that something is going to be effective in a larger group of people. So you can't do this kind of research and get bogged down in the experiences of one patient. The system itself is not designed that way.
I'm a former teacher, so if something doesn't work, my first instinct is we need to find out why it didn't work.
Yes, 100%.
Right. But that's not happening.
No,
it's not happening. And the other thing that concerns me too is that there could be very valid drugs that could work for a lot of patients, and they get thrown away because they're not used on the right patient. And how the thing that I'm working on right now with this young doctor is he discovered a blood test where there's a genetic mutation on the HLA, human leukocyte antigen, where if you've got this particular mutation, which there wasn't a test for before, you won't respond to immunotherapy that targets an antigen because it hides the antigen from the cancer. It hides what you're looking for. And so we want to help as many as we can. We want to make sure we're giving them the right drugs, because this new HLA thing, I'm thinking, well, geez, probably anybody in any immunotherapy trial who's got this mutation, which by the way, we don't know how to fix yet, but they're not going to respond to immunotherapy. So number one, not only is it bad for the drug, which could be effective in many people, but it's also bad for the patient because they're on this trial and they're hoping, and meanwhile, they're not looking at alternatives.
But that is the risk that every patient takes, that once you commit to a line of treatment or commit to participation in a trial, that you're not looking beyond that. And that is as a lawyer, I'm always worried about informed consents, right? And people walking into these experiences really being informed fully about what they're really doing. And unfortunately, I do think that if most people really understood, they wouldn't participate in clinical trials. Yeah. And so there's a little bit of glossing over some of that happens because the patients are having to accept a much bigger risk than most patients are fully aware of. Is it a risk that often pays off? Of course. Is it a risk that is necessary in order to move research forward? Absolutely. Can the system do a better job of really informing patients what they're getting into? Yeah, the system absolutely can. I'm not saying any particular person. I'm just saying generally, having participated in as many trials as I have, the lack of information has been the hallmark, not good information.
But also, like, you are an educated, experienced, like you are obviously your best advocate, your own best advocate, right? And
yeah,
I don't feel like a lot of people have the strength to do that, right?
They don't. And the longer I've lived with MBC, the harder it is, because in order to advocate for yourself, you are having to push against an entire system that is absolutely arrayed against you, 100%, because it's the lowest common denominator. It's systems, it's protocols, it's patterns. Any individual person who's saying, no, I don't want to do it that way because that's not good for me, you are swimming uphill. And that is an effort that the vast majority of people are unable to sustain for any period of time.
Well, it's exhausting.
So people give up.
It's a double-edged sword because you're fighting the effects of treatment, and then you're fighting the energy to look for other options too. That it's exhausting to do that.
No, it absolutely is. And there are lots of bright spots, right? There are lots of people who go above and beyond and do their best, within a system. It's just that to constantly and consistently speak up, it is a really tall order. And this whole idea of medical gaslighting, where women generally, our symptoms are discounted, our pain is discounted. There's a lot of that embedded misogyny in the system itself that we're running into. And that's not specific to cancer, right? That's all across health issues. But it becomes very, very difficult. And, I began this process with, a whole lot of education, and I did a fair amount of medical malpractice when I was practicing as a lawyer. So there were things that I knew differently than other people walking into the situation. So that's where I come back to, there are basic health literacy things that we have to start with in order for patients to be able to even fully participate in their own care.
Yeah.
And that's a huge issue.
First of all, thank you so much. And we'll talk, I hope we can talk again, but
Yeah.
if you had an ask of one, that's not one thing, but if you could have an ask to ask for something to change, would there be one major thing that you'd like changed?
I think the biggest thing that I would like to see changed is for patients to be involved in at the beginning.
Okay.
I tell doctors all the time, patients make decisions. Doctors don't make decisions. The system itself is set up in this idea that the doctor is the boss.
Mm-hmm.
The doctor's not the boss. The patient is the boss. Mm-hmm. And that idea involving patients and reiterating to patients from the beginning is your decision. Here's my recommendation. Here's my expertise. Here's my, education. Here's all the things that I know. But you, patient, you make the decision about what's best for you. That as a consistent theme is missing. And that is legally, no doctor can make decisions for patients. I mean, unless it's a specific emergency situation and you're, not able to communicate and things like that. Obviously, there are specific situations. But the vast majority of medical decisions, many people that I've talked to feel like things are being imposed on them, and it shouldn't be imposed on them. Patients get to make decisions.
This recent NBCC summit, they did reinforce that if you're going to write a letter of recommendation for an investigator on a trial, you better be involved from the beginning, not just say, okay, I'm going to write you a letter when you don't really know what's going to happen later on. And you need to be, like you said, involved from the beginning, and you need to follow through till the end.
Well, a lot of times they don't ask for advocate input until the very last second. And so there's not any way to meaningfully be involved, which is part of the reason why I've started turning some projects down, just because if, number one, time, but number two, if the proposal is due tomorrow, like obviously I can't dig into what you're doing and understand it. So yeah, I mean, I think it's incumbent upon the researchers to know what's required for funding and to prepare. And that's can be hit or miss.
Well, I just appreciate your time so much. And I really want to know more about your experience, and we can maybe arrange another meeting. I'd really appreciate it.
Yeah, sure, absolutely.
Gosh, I just wish you all the best, and
thank you.
Pray for you. And I had two sons, and when I was diagnosed, I was obviously much older than you. And my one prayer when I didn't know what was going to happen was I wanted to see them get married. Now they're both married. I've seen this is my last grandchild I'm going to have. When I was a teacher, I used to tell my class, pay it forward. Having said that, it's been amazing. Are you going to San Antonio?
Yes.
Okay. Okay. So we'll get to meet in person too. Yeah, I'm going to go.
Okay. It was a little, I was very disappointed that they decided to start charging advocates. I mean, it's hard enough. The financial toxicity is hard enough that they would do that. So yeah, anyway.
The airfare and the lodging. Well, again, thank you. I'll be in touch, and we'll see each other again.
All right. Sounds good. Have a great rest of your day.
Thank you so much, Abigail. This has been a great pleasure for me.
Thanks for the invitation.
Thank you. Bye-bye now. Thank you for joining us today. And for more information, go to www.sisters4prevention.com. A very special thank you to my guest today, Abigail Johnston, Esquire, who does so much for so many people in the breast cancer arena, particularly metastatic breast cancer. I will post links to some of the articles on the great work that she is doing in the comments. So till next time, stay safe and may God bless. Thank you.